So without further ado, I'm going to turn the podium over to our friends at Cystic Fibrosis.
Thanks for joining us today. What we hope to cover today is first to align our voice with the slides, but is to tell you a little bit about our journey with cystic fibrosis to get access to treatments. And we're going to start with telling you a little bit about what cystic fibrosis is, some of the life-changing treatments that we've had and the impact on the disease. We're going to then share our UK access story, a little bit about our Canadian story to access, and then have a bit of a discussion with you. And I'm joined today with Dr. John Wallenburg, who's our Chief Scientific Officer at Cystic Fibrosis Canada, and David Ramsden, who is the CEO of the UK Trust, or of the CF Trust in the UK. So I'm going to pass it to John, and then we'll hear from David.
Thank you, Kelly. And so just a little bit of the background behind the disease, because it's important, I think, to understand both the severity of the disease and the power of the drugs that were coming down the pipeline to understand the sense of urgency behind the advocacy efforts and the government relations that we were doing. So cystic fibrosis is a genetic disease. So as I said, as you saw in the recording, it's caused by mutations in a single gene. It's inherited. It's not acquired. So like blue eyes, red hair, it is recessive as well. And both genes need to be mutated for a child to have cystic fibrosis. It's estimated between 1 in 25 and 1 in 30 Caucasians as a carrier. I'm a CF parent and therefore a carrier. Carriers don't have signs of the disease. However, when two carriers get together, there's a 1 in 4 risk of children having a cystic fibrosis. It is a rare disease with about 1 diagnosis per 3,600 live births. So it's one of the more common rare diseases, but it is a rare disease. It's now included in newborn screening in most of the Western world and most frequently diagnosed shortly after birth. Although it's caused by a mutation in a single gene, it's a multi-organ disease. Mutations in the CF gene lead to a defective protein called CFTR for short, doesn't matter why. It is expressed in the body systems that are in direct contact with the outside world. Think of, the organs that have mucus, your digestive system, the reproductive organs, but the most important clinical impact is in the respiratory system. Normal CFTR is an ion channel. It works like a window in the wall of the cell. It opens and closes and allows ion exchange, which in turn helps keep mucus liquid. There are over 2,000 mutations of the CF gene, and in many cases, protein is made, but it's mutated and it never gets installed in the wall of the cell, or if it does get installed, it doesn't work properly. This leads to thick, sticky mucus that causes problems like plugging up the tiny ducts that you have in the pancreas that produces the digestive enzymes that you need to digest your food, or along the walls of the intestine where it interferes with food absorption, or in the lungs where it can block the tiny airway passages and also serve as a medium for the growth of bacteria and fungal spores that people breathe in. This in turn leads to chronic infections. People with CF also have a poorly understood immune dysfunction that leads to cycles of excessive inflammation and infection, which in turn lead to lung damage, scarring, and progressive loss of lung function. 85% of people with cystic fibrosis will die of respiratory failure. Double lung transplants are the last recourse for end-stage disease, and patients are placed on transplant list once their lung function consistently falls below 30% of normal, at which point climbing a flight of stairs is a major accomplishment, as I said earlier. In the early 1960s, people who were born with cystic fibrosis were not expected to go to school. Median age of survival was in the single digits. Already by 1984, the median age of survival had increased to 25 years, and it has continued to increase almost 1 year for every year of research and clinical improvement over that time. So Canadians born with cystic fibrosis in 2019 have a median age of survival of 54 years. That's pretty incredible. But nearly all of that incredible progress has been achieved by treating the symptoms of the disease. The byproduct, a heavy treatment burden that includes a vast number of drugs to treat symptoms individually, one at a time. Intravenous or inhaled antibiotics to treat lung infections, enzymes to help digestion, or food supplements to help compensate for poor absorption, insulin for cystic fibrosis-related diabetes, anti-inflammatories to fight the inflammation in the lungs especially, and the list goes on. In addition, there are physical therapies to help clear the lungs. People living with cystic fibrosis typically spend between 2 and 4 hours of therapy daily just to try and stabilize their health and decrease the rate of progression. Patients typically attend hospital-based multidisciplinary clinics once every quarter. 10 years after the gene was discovered in Canada in 1989, our sister organization in the US, the CFS, started investing in drug screens to find a drug that would correct the problem. And using the deep understanding of the biology, those screens ultimately proved successful. The first drug was a drug called ivacaftor, sold as Kalydeco and approved in Canada in 2012. It is the first drug in the history of the disease that targeted the upstream cause of the symptoms rather than the symptoms themselves. And clinical impact was also very significant. When Kalydeco first came to market, it was believed that the loss of lung function was irreversible, and the success of ivacaftor was truly astonishing and hugely promising. 2 years after ivacaftor came to market, the second generation CFTR modulator came to market. It was a combination of two drugs, the first ivacaftor and lumacaftor, and the second of these was a combination of ivacaftor tezacaftor. You can understand that since these drugs fix the defective protein, they're mutation specific to at least to a class of mutations. The second generation was hugely important because it targeted the most common mutation in the North American populations, called delta F508. So 50% of Canadians with CF have two copies of delta F508. However, the efficacy of the second generation of drugs was not nearly as good as the first generation. It only led to like a 3 or 4% improvement in lung function. Nonetheless, you could say, you know, there were a number of patients, 1 in 8 would see an ivacaftor-like benefit. In spite of the clinical benefit of the second generation drug, the cost effectiveness of this drug was both deemed insufficient by the Canadian system, and neither drug ever got more than compassionate coverage through the public system and only in one province. While the rest of the OECD comparator countries slowly gained access to them, at least we weren't alone. The United Kingdom refused to pay for them as well. The cystic fibrosis community watched with great anticipation as the third generation of these drugs worked its way through clinical trials. Trikafta is a combination of 3 drugs, including the first generation ivacaftor. The clinical trial results were stunning. Not only did it lead to improved even better clinical outcomes than ivacaftor alone, it was capable of treating patients with a single copy of delta F508. That meant Trikafta has the potential of bringing truly significant clinical benefit to 90% of Canadians living with the cystic fibrosis. Trikafta was also important. It was so important that the FDA used all mechanisms it had to review rapidly, and it brought the drug approval ahead by 6 months ahead of schedule. In late October of 2019, the Washington Post described it as the #1 good thing to happen in 2019. To add insult to injury for Canadians, the UK approved Orkambi and Symkevi, as Symdeko is called in Europe, at the same time. Canadians with CF were feeling truly abandoned. And one last thing I do want to mention is that I mentioned that median age of survival for somebody born in 2019 is 52. Bear in mind that for people who are alive today, half of the people who died in 2018 were under the age of 32. So there is still, it is still a very serious disease. It's not like everybody with the disease is living to median age of 52. And I should pass it over to David at this point in time.
Okay, well, thanks. Thanks for having me. And sorry, that's been a little bit delayed. And I join you from actually a very sunny London lunchtime. So I know my kids will be very envious of the snow that's dropped on Montreal, but we'll have to wait for that and probably get a small smattering to try and make a single snowball. But I want to talk a little bit about our experience, and I'm conscious of time, so I'll run through this quite quickly. But first thing to start with, the UK is 4 nations. And that actually is an important part of this story because that's 4 jurisdictions in terms of making drug decisions. We have about 10,500 people with cystic fibrosis in the UK, which makes us the 2nd largest population in the world, which owes its origins to what John was talking about in terms of its genetic heritage. And obviously there are different mutation groups in that population, which is pertinent to the medicines that John was talking about. We are trying to achieve overall has been access to precision medicines, and the most recent being Kaftrio. And as John pointed out, helpfully Europe and North America have different names, but that's Trikafta, which you will have heard referred to. But the journey started with Symkevi and Orkambi, or the battle, because actually ivacaftor that preceded them was obtained through an earlier campaign. Again, I won't dwell on this, but this shows the lung decline that we experience, the respiratory failure that is the most lethal factor of cystic fibrosis. And you can see how that progressively declines. And the critical thing about the drugs is their ability to arrest that decline, but also being mindful that they're not curative medicines. And if you wonder why that goes up a little bit towards the end of the graph, that's obviously the impact of survivors, basically, in that some people have passed away, therefore the average position for people will increase to some extent at the end. I thought, to build on John's point, this is a pyramid of where people are at in terms of age demographics over a 10-year period between 2009 and 2019. And you can see that there's a positive move upwards, i.e. chunkier bars in higher ages, but we're still talking about a median age of 21, and in the UK also a median age of death in 2019 of 32. A point when most of us, certainly I was, looking to start out and make some significant decisions in life. That is when people are coming to the end of their life, which, although all of the progression we've been talking about through improvements in clinical care, this remains a critical life-limiting condition that is extremely life-shortening to people who unfortunately have a diagnosis. So we've had a big leap in 2019 and 2020, but that was built over many years, really 4 years of work. And it all started back in 2016 when NICE, which is our clinical regulatory body, said no to Orkambi. And they did it, as John said, on the value for money basis, that they didn't think the clinical improvement was worth the value. And we were at that point deeply frustrated because we knew the clinical benefit would be something that would help to arrest the decline in people with cystic fibrosis, and actually critically act as a bridge to the therapies that we already knew were being developed. So let me talk through a few of the areas of what we were doing from that period, 2016 onwards, and I won't run through them all because I'm going to go through them in a little bit more detail, but I think one point I wanted to emphasize is this is very much from our perspective, as in the perspective of the UK Trust. It actually was a truly community-wide campaign. And the planning and coordinating the final P there that we did between different active groups and people across that campaign was absolutely fundamental to its success. But I thought I'd shine a little light on some of the things that we were doing. So firstly, we were very active in policy, and it's important to, as we are the only national UK cystic fibrosis body in the UK, that we got active and thoughtful with the key decision makers, which in the UK are the NHS. We have a single payer system, although it's stretched out across the 4 nations. We obviously also have NICE that I was talking about, which is the regulatory body, and we have Vertex, which is the pharmaceutical company. And we wanted to use the data and that we have from our cystic fibrosis registry, but be a thoughtful and constructive partner in those policy-making decisions, really get into how the decisions made. And that takes expertise and work and ensuring that you have the right skills on your team and you can access the right skills to do it. We also got very active with press and publicity. I mean, first I'll talk about print and then online. It was really important to get out there and start to tell the stories of people's lives with cystic fibrosis, and particularly the hook that this was an injustice. That there was a drug out there that could help people that was being denied to them. And that lands well in the context of a National Health Service, which is there to support people's lifelong needs. But you can see there, we've got a piece in The Guardian. We've also got, towards the more popular press, the Daily Express, who were long-standing partners of us through the campaign. We also used press and publicity and to highlight and magnify what remains a significant but a small community compared to some others. We were conscious that although many family lives will be affected by cancers, actually with 10,500 people affected by cystic fibrosis, you're talking about a smaller population, which is why it's important to try and go mass in terms of maximizing with publicity. As you can see in the bottom left-hand corner there and in the top of the screen, it was very important to get the voices of people who were directly affected by cystic fibrosis talking about what their lives were currently like and what these drugs potentially meant to them. We also increasingly found that the way both to motivate, inform, and to go to scale was to use social media. And I've included this slide because I like the fact that we've got Jenny Agata, who some of you will be familiar with, who's from Call the Midwife and The Railway Children many years before that, who's one of our patrons, and Jeremy Corbyn, who was at the time of this campaigning the leader of the UK Labour Party, both tweeting about the same issue and us using it as a way of galvanizing protest. And protest is important. And as I said earlier, getting out across the 4 nations. So there's us handing in a petition in Wales, outside the Northern Ireland Assembly. up in Scotland and outside Westminster. And again, we were pleased that we could activate small numbers of people. We want, the larger the crowd, the better. But it's amazing the impact of actually the number, a relatively small number of people directly interacting with the parliamentarians. And in fact, in the top left, we have parliamentarians who are holding some of those placards. And you'll see as well that we've tried to keep our message simple around life-saving drugs now. Not getting it, we actually transitioned from talking about the specific drugs because we found that you get mired into elements of explanation. Working with people, this is a slide of lots of happy smiling faces of me, which shows how well some of the meetings have gone. But this is just an illustration of the corridors that we were walking down and the people that we were meeting. The top left-hand corner is up at Westminster again, and we've got various secretaries of state left and right. And in the middle, that's the chief executive of the pharma company. Having access to those people to put directly to them the consequences of the failure to access these medicines, but also to galvanize them into action was very critical, because one of these things is to make this newsworthy, to drive this up the political agenda. And again, another example here, there's a smiling face in this one, because what looks like quite an innocuous cup of tea was a really significant meeting, because the woman on the left was chair of the House of Commons Health and Social Care Committee, and she was able to initiate an inquiry which brought forward the activity in the bottom right there, which is both the leaders of NICE and key decision makers in the NHS with the pharma companies called to give evidence as to why this deal wasn't being done. So they weren't making a view on what the deal should be, but they were drawing out the individuals to explain and therefore go on record as to why people were being denied access to these drugs, which I think was a really important part in driving us forward to a solution. And again, you can see I was lobbying there with that Secretary of State and critically using all the devices that were available. So I know that your parliaments differ, but we had a trigger in the Westminster Parliament that if you get over 100,000 signatures on a petition, which for a community of 10,500 people can be quite an accomplishment, there is a committee that has to consider whether or not a debate is held on the subject. And twice we were able to hold debates in Parliament as a result of getting a petition to that point. And again, that got dozens of politicians talking about it and created campaign momentum, because you are constantly, particularly as we have things like Brexit that we used to talk about, you're constantly trying to actually get towards the top of the agenda to make people feel that this is something that a decision needs to be taken on. Cross-parliamentary support was critical, and this shows how it built. Various mentions and references to the drugs and to cystic fibrosis and the trust built over time. This can take time because you're building pace, you're informing people. You may have general elections where you have to induct and inform new people into the debate. And then we ended up in June 2020 with, I won't play that full video now, but that was the same guy who was health secretary thwarting us 3 years ago, announcing now as chair of the Health and Social Care Committee that a decision had been taken to fully fund Kaftrio, which is a truly transformative drug for all eligible adults in England and with equivalent deals in Scotland, Northern Ireland and Wales. Very briefly, because I'm conscious of time, some things about what worked and what did we learn. People, really important. As I said right at the beginning, this was our perspective, but we worked with lots of different people and lots of parts of the community and other actually external groups and opinion leading organizations. And you would have different tactics. It's really important to remain focused on the fact that you have the same goal, because it is possible to fall out, which I'll mention in a minute. Personal, the engine, the fuel is stories, particularly from the press and the media. What they want to talk about is the individual stories of people's lives. That's what is the leverage into the wider debate. Passion is absolutely critical. You've got to sell this strongly for the reasons I was saying before to get this up the agenda. But certainly from our perspective, we felt that anger didn't work. Outrage and injustice is important, but we felt that anger was potentially toxic to some of the relationships we needed to generate over the period of time that we're talking about. And then persistence is critical because, as I've laid out, it's a long haul, but so is pace. And by that I mean is you can't be at peak all the time. And it's really important that you choose the moments, particularly rallying the community, you choose the moments to intensify effort. What didn't work so well, I think, people, just to the flip side is, rightly, people are very passionate. People right in the heart of this and knowing what the drugs would mean to them and their families. And at times we came close to, having very different views on a particular issue. And I think it's really important that you don't allow that to become a distraction from the point earlier, which is same goal, different tactics. One thing I would caution is to not get drawn into a debate over price. We certainly got pushed on occasion. So, well, if you think it's too if NICE says it's too expensive, what do you think is the right price? We were very clear that was not our policy. It's not appropriate for a charitable body to be drawn on evaluating the value of a drug. What we are clear is there's a pharmaceutical company that wants to make money on a drug that delivers value for people with cystic, delivers effective difference for people with cystic fibrosis, and a health service that is committed to the health of its population. There should be a way of triangulating that to deliver a result. Now, press is be open. I only put that there because press is, can be a double-edged sword. I think it's really important that, particularly when you're working closely with pharma or you engage with pharma in some way, you're very clear in all your public pronouncements and on your published material what your relationship is, so that it isn't misconstrued in any way and you're not seen as lobbying for that company. And in politics, as I referenced earlier, it's critical, don't choose sides. I think it's important that this isn't turned into a party political issue, because I think that runs a real risk that you'll end up on the wrong side of a debate. I also wanted to very briefly at the end reflect on the psychological impact before and after. And that's both during the campaign because of the intensity and the size of the prize, but also actually as we have been successful, it's been really striking about the range of psychological responses that people have experienced, both the elation of getting the drug and it being successful for them, but also the frustration and despair of perhaps not having the appropriate mutation, perhaps not responding in the way that they anticipated, or in some cases, the guilt that they have been around and are able to benefit from these drugs when others aren't. So actually the mental well-being side of this campaign is a really important one to bear in mind. And that's a final slide, really, just to say that politicians as well, that's our Prime Minister with a young girl who is benefiting from the drugs. Politicians also like success and like to be associated with success. So I think also building the momentum of that campaign with the pace and persistence to recognize that this is something that people will want to be part of, making a difference. Because actually a lot of politicians go into politics to make a genuine difference. And if you can tap into that across party, I think you have a real chance of building the momentum that will succeed. I spared you having to see me during that, but I'll now stop sharing and turn my camera on. So I think we're going back to Kelly now, though. Thank you.
So this is really very, very briefly, I don't want to dwell on this one. This just shows the Canadian approval system. You can see it's complex. It's rather convoluted. One of the things I need to point out, in the same way that David said, UK is 4 nations. The healthcare system in Canada is not a national system. It's actually run by the provinces. There's some federal positions, but mostly it's run by the 10 provinces. And this shows where the different drugs are available. You enter the system up here. Once you're approved by Health Canada for safety and efficacy, you can come rapidly down, and through private payers, you can make it to the public. If you're going through the public, so Canada also has a public system and a private system. So this is the route through the private system for those with private healthcare. And for public coverage, you need to go through a public healthcare technology assessment. You got to go through pricing negotiations, and then each province individually has to decide whether it's going to be putting it on its public formulary before it even gets to patients. I think we'll then move on to the next slide, Kelly.
Great. So as John said it earlier, there were different drugs that came at different times. So our work to improve access in Canada has changed over time. In fact, I would say there's just completely different phases. So in the beginning, when we had the first drug become available, Kalydeco, it was beneficial to a low percentage of our community. So there was some interest, but it was limited. And most of the work that was done was really by individual activists. And you can see the mom and the daughter up there. They were very successful and able to get access. Over time, though, as the drugs have become more relevant to more of our population, we've had more of a fulsome and comprehensive strategy. And I'm going to take you through some of our strategies now. Next slide. So a large part of our strategy has been focused on government relations, as David's has as well. Our work has been both focused at the provincial and the federal level because of the way our system is, or what we, if we wanted impact, it would depend on where we came in on it. To impact government, we held meetings with elected representatives, those that we knew we could have influence over, like the Minister of Health, the Minister of Finance. We also had our members of the CF community meet with their local elected representatives. That's really important in Canada. Local reps must meet with their constituents and bring their issues forward. And so that was really, as I said, helpful. We had a challenge during CF May Awareness Month, challenging our community to meet with their federal elected representatives so that we could meet with as many as possible during that time. Sorry, my puppy is barking now. We also held lobby days, which means there is a certain period of time when meetings are booked with elected representatives and you draw attention on a particular issue. We conducted letter writing. We had 5,500 letters written to almost 99% of members of parliament. We also conducted petitions because they will be read in the House of Commons, and it gave us a lot of profile. And with so many people writing letters and meeting with their local representatives, we found champions in different parties, and they asked a lot of questions in the House of Commons. It provided profile for us, but it also provided profile for them. So that led to a historic all-party access meeting on Tricafta, which had all members of, or had members from different political parties. Next slide, John. We also use public relations to influence strategies as well, or to influence access as well. We use the traditional media by conducting press conferences and pitching to the media. We wrote op-eds and letters to the editor. We leveraged the stories of our community and shared them with the media. And most recently, we had a very successful letter writing a letter to the editor initiative, whereby our CF community wrote letters to their local papers, and we had 200 letters published. We also found champions in the media, and we ensured to keep them up to speed. And we used social media, and that created a lot of momentum for us online. Next slide. Engaging the community helped on the other two strategies and also was a very important strategy in and on itself. To begin, we built an advocacy network of trained advocates from coast to coast. There are 250 of them now, and we've leveraged this network to help us do our government relations and public relations. With the interest in Tricafta, the interest in the community exploded, and we had to broaden our work to ensure that the whole CF community had support to advocate. So we provided tools for the larger community to use. These included a toolkit on how to participate in the advocacy, a turnkey letter writing online tool, social media hashtags, and shared content. We were a little slow in building our tools for the larger community, and we saw the rise of an informal group of CF patients and families called CF Get Loud, and I think some of you are familiar with them. This group started to fill a really important void that they felt we weren't filling, to push hard and fast for access to Tricafta. And while it was really hard for us to think that we weren't doing enough for the community, we know how important it was that they developed, because it was a true grassroots patient group, and that their presence was so important in galvanizing this issue and galvanizing the community. Next slide. In terms of lessons learned, we learned a lot. So in terms of government relations, we learned having a network of trained advocates gave us leverage and extended the reach of our staff. And it is a really big country, so that was really important. Working at the local level was really helpful. As I said, they had to meet with us, and through that work, we built champions who otherwise might not have been given opportunities to shine. Timing is everything. Sometimes it worked for us. We had a big policy change in pricing control in Canada happening, and that gave us a lot of press. And sometimes timing doesn't work. So this picture here shows us having a press conference in Ottawa last March. And as we walked into the room, all the media walked out following the Prime Minister, who had just announced we were in a COVID pandemic. So not always working. Embarrassment tactics, they did work in the early days when advocacy took place for Kaleido, but the pushback was very strong this time around. And finally, an important lesson we learned is we should have brought clinicians into the work earlier. It is very important, as decision makers really truly do listen to the voices of clinicians. Next slide. Regarding public relations, we also had some tricky ground to navigate with respect to the cost of the drug and the reputation of the manufacturer. We learned to steer away from the messaging about cost and the manufacturer, but honestly, it was difficult and we weren't always successful. Being aware that this might be an issue for you might be of some help. Having personal and varied stories to share with the media was really important. It helped to get the interest of the media at the local level and generated a lot of press. Also, we made the issue broader and part of the dialogue on rare diseases and on precision medicines. And this helped to get interest. And I saw a note in the chat while I was waiting about whether we made this a human rights issue, and at times we did. Our lessons learned with respect to community engagement. So the first thing I will say is this: if you have a drug that is truly transformative, or you haven't had a drug for some time for a disease such as ALS, remember that your community will not want to sit back, and nor should they. They will want to be involved, and they should be involved, and they'll want to know that this is a priority for you. We learned that, and we weren't providing enough communications on what we were doing to improve access. And so we did that. We shared frequent and open communication about what we were doing, what the status of things are, and why things weren't moving fast enough. Also give people concrete action to take. And sometimes that's as simple as using social media. Building a relationship with our grassroots partner, community partner, CF Get Loud, was so instrumental to our work. It was really important that we got on the same message and strategies and worked together on our strategies. Sometimes that took us a bit of time to figure that out, but it was worth it. You need to be seen to be working together, or it splinters the message, or it detracts from the work you're doing because people focus on that. And remember, as David said, this work is emotional. It's emotional for staff. It's emotional for your community. And please give people the space to share and emote. Next slide, John. Overall, I'd say this: you need all strategies. You need a comprehensive strategy. So keep your eye on all fronts. Work together and leverage each other's strengths, and keep your head down and keep going. And with persistence, you can get to this. Next slide. This is a picture of our team when we learned that Trikafta was going to be submitted to Health Canada, and we never thought that day would come. So I know your day is going to come too, and thank you for listening, and thank you for putting up with our technology challenges today.
Thanks, everyone. And Kelly, I did want to add one thing. There was a comment in one of the comments about the pity press, and one of the things that we did to sort of not sink into that really was to point out how this was relevant for everybody. You know, as the direction that medicine is going in is that, you know, we're getting better and better at defining diseases. You know, what was breast cancer many years ago is now 20 different diseases. And so we're able to point out that it doesn't matter what disease you have. When there is a new drug coming, it's you know, it's important to get it out to the population. And so this wasn't a CF thing. I mean, the ability to access really life-changing drugs is important for everybody. So, and I have no idea what is just zooming in on me like that. Okay.
Thank you very much, Kelly and David and John. We really appreciate you sharing these stories. I think with ALS, as we're looking at the potential of therapies coming to market, we're getting through clinical trials and we're starting to see some drugs now enter in. Some of the question is, how do you navigate the expectations as well, especially when you're dealing with therapies that aren't a home run right out of the gate? And so what does that mean? And, you know, as you're looking at the dealing with the regulators, you've got the first regulatory decisions, and then you've got the access in terms of reimbursement. So can you give us any insights there as you might have entered into it?
Well, could I respond to that, if that's okay? So
Please.
I think there's I think it's a very good point. Because you can be getting into a situation where you're over-promising in that, or perceived as over-promising. I think for us, and I don't know if I think it probably will be similar in your situation. I think the fact that cystic fibrosis is a progressive disease was important. So actually what we were saying is, look, there are drugs available which have the potential to slow the progression of this disease. They're not curative, but we know at the moment people have the burden of care each day, burden of treatment that John was describing, and these are the best tools available for the clinicians to use that have the potential to slow the progression of this disease and buy time for the next generation of treatments to come. I have to say, in the hands of a sub-editor, that becomes life-saving drugs or, wonder drug. And actually, there's a bit of shrugging our shoulders of that. It just because actually we also need to be realistic that connecting with the transformative nature or the perceived transformative nature of the drugs is important for the column inches you can get. I think it's important that you have an educational and information strand and going along in parallel. And picking up on a point that Kelly made, the clinicians, certainly in our case, they come on board when they feel that they were a little reluctant to come on board with the first set of drugs, but actually their enthusiastic support for the next generation of drugs was fundamental to the pace at which we were able to achieve that. So I hope that answers that question to some extent.
Thank you. And John, you had mentioned that there was a delay between when you saw the therapies coming to market in other areas and when they came to Canada. How much did you work with the international community to be able to help navigate that? And did you see a difference? Because as we're seeing that for ALS, we're seeing therapies that might be approved in the US, even as we try to get them into Canada, but there could be further delays in other countries. And so how do you navigate that sort of expectation and that change as well? And how much do you use it?
So we're certainly aware of what our sister organization in the United States was doing, and we were learning from them in terms of some of their interactions. I don't know, Kelly, if you have more that you wanted to say about what we learned from what was going on around the world.
I think, well, we shared strategy. We would ask them about their strategies of, so in the US at the time, David he just had learned about Orkambi, I think at that time. And so we learned about what they did up front with the FDA that will help us now as we meet with Health Canada. I think we also learned sort of about, to your earlier point, about expectations from payers or expectations from the community. And David really has been a really, because they've been one step ahead of us. So learning from what their experience has been has really helped us think through the stage we're in now. David, and in Ireland as well, they've talked to us about how the sadness some people feel because this drug is not for everyone. It's 90%, so it's really exciting, but there's 10% or 5%, depending on whose figures you use, that this won't be for. And so, that's been a big challenge, and we've learned a lot. So while we felt very sad for ourselves and for our community that we have not had any access, we actually have benefited from the learnings from all our other, from the other countries.
There's one other thing that I would highlight, Tammy, as well. What we also did is we tried to take advantage of the situation where we were without a certain class of drug to go to the competitors of the manufacturer and say, you want to run clinical trials on the next generation of drugs or on your competitive products, please come to Canada as fast as possible because we've got a population that's really anxious to get this drug, and we have this naive population that's good to test your drugs on.
Okay.
Could I add a comment as well? Because I think one of the things that I think there's a good comment in the chat there about the work required to get the drugs you need. And one of the things that we've tried to do as we've progressed through our campaign is to work with others and actually bodies in the UK, like there's a charity I'm also involved in, which is across all genetic conditions, to say, look, this is just wrong. It shouldn't be based on the articulacy, or if that's even the right way of saying articulate, the sophistication of the campaigning resources of a particular group of people, because that inevitably is going to lead to unfairness. Actually, you need to have a system that recognizes that these precision novel therapies are coming through and can respond accordingly. So actually what we were going back to what I think John was saying a few moments ago, we to twist my metaphors, we tried to say, look, we're the canary in the coal mine here. We're a very data rich condition. We have a registry. We know we can track progress. If you want data, we can do post-authorization analysis very sophisticatedly. If you're not funding it in CF, what are you going to fund? And actually, at that point, you start to ask them very deep-seated questions about what the health providing systems are in place to do. And hopefully that we punch a bit of a hole in the wall, certainly in the UK, that others can come through after us without having to work out how much they can wave a placard outside Westminster on a cold Wednesday.
Excellent. Thank you very much to all three of you for sharing. You know, this really helps to build on some of the conversations that we had last year at the Alliance as we started to talk about working with pharmaceutical companies and what it means to the ALS population. And, you know, we're fortunate that we have such a strong international alliance as we have with these meetings today. And so being able to learn from the experience of CF, and I know from our experience of working together with CF and the other health charities in the coalition in Canada, it's made a big difference. And I completely agree that together we can get much further. So I would like to thank all three of you for bearing with us this morning. And now you can take off your tap dancing shoes and go and grab a coffee and relax for the rest of your day. And we are going to move on to the rest of our presentation. So thank you, Kelly, John, and David for sharing your experience. I know that we've learned a lot from you this morning.
Thanks,
Well,
guys, and
thanks
good
for the
luck with the rest of
opportunity.
your event.
And
All
good
right.
luck with everything, including getting the drugs approved and
Absolutely.
to patients.
That's what we will next be shouldering into as we move through the rest of our day.